This is Dr. Howard Strassler, and today I'll be speaking to you about fiber-reinforced composites for periodontal splinting and single-visit composite bridges. When we talk about splinting teeth, periodontally involved teeth, teeth that have been periodontally compromised, the rationale for controlling tooth mobility for these periodontal cases is to control primary occlusal trauma, basically excessive occlusal forces, in a normal periodontal, with normal periodontal support. We can control mobility where mobility is present due to secondary occlusal trauma, where we see normal occlusal forces, but the periodontal support is inadequate. We have bone loss, periodontal pocketing. We also control tooth mobility and migration of teeth, spacing, and for the patient, pain upon function. In fact, that typically is the patient's chief complaint, that they notice their teeth spacing out, they've gotten spaces between their teeth, as well as when they eat certain foods, the teeth hurt. And typically, these can be the anterior teeth, which is what we usually see, but also posteriorly involved, periodontally involved teeth also can have discomfort and some of the same symptoms. So we want to control tooth mobility. What methods can we use to control tooth mobility at many different levels? We know from the literature that periodontal splinting improves periodontal prognosis. If we stabilize teeth, along with controlling occlusion, along with controlling the periodontal disease by scaling and root planing and soft tissue management, we can improve the periodontal prognosis of teeth that are periodontally involved. We know from the research articles, going back to the Amsterdam 25-year retrospective study in Alpha Omega, and other articles, that the evidence really strongly supports splinting of teeth that are periodontally involved. The decision to splint teeth to control mobility should be based upon patient discomfort, decreased occlusal, and masticatory function. As you can see with this patient, with the images to the right-hand side, this patient has severe periodontal disease. The mobility of these teeth are a grade 3 mobility. And in fact, after scaling and root planing the teeth, we can control the soft tissue inflammation, and now we need to also control the mobility. There are many different ways of periodontally splinting teeth. 25 to 30 years ago, it was not uncommon to use a cast metal framework that was connected to the teeth using pins that were placed from the facial surface. You can see that the central incisor, one of them is discolored because it's endodontically involved and endodontically treated. One of the things that we can do is we can mask that discoloration and, in fact, place facial bonding to control that discoloration and end up with an aesthetic result. This splint has been in place for over 25 years and functioning very, very well. The first adhesive bridges that were placed used what was called a Rochette retainer, a cast metal framework with holes, perforations placed in the metal, and then the metal framework was cemented to the teeth using a bonding composite. The composite would lock into the perforations and lock the framework in place. One problem is that the teeth would come loose from the perforations, the composite would break down. For this patient with a periodontally involved incisor, mandibular incisor, after the splint was placed, the root was removed, but the crown was maintained intact. We then were able to do periodontal splinting with etched metal cast frameworks, what you might know as Maryland bridges, that the metal was either electrolytically etched and later sandblasted. We were using base metal, nickel chrome alloy metals, that could be treated on their inner surfaces, made microscopically rough, and bonded with bonding composites to the lingual surfaces of the mandibular teeth and the lingual surfaces of the maxillary teeth. And if placed correctly and the teeth stabilized correctly, these did very well. A problem, though, that occurs with mobile teeth is these mobile teeth move. They move facial-lingually. They're depressible. They torque and twist within the socket. In fact, without any cross-stabilization on the facial, it was not unusual to see a tooth walk out of splint and actually come free from the metal, which meant removing the entire splint itself. Some of our earliest periodontal splinting was with orthodontic wire, where we take the wire, twist it around the mobile teeth, and then cover it with an acrylic resin. This would be similar to jet acrylic. And the problem that you had is acrylic resins discolor over time. This wasn't done with an adhesive technique, and these splints were strong and stable, but not very durable and not very aesthetic. When we started to work with adhesive composites, the manufacturers, the researchers, came up with using metal meshworks. Here we're seeing metal meshworks that are similar to a screen door, to perforated metal. In fact, nylon grids were also used. They were placed and embedded into an adhesive composite, placed on the lingual surfaces of teeth, maxillary, mandibular incisors. But over time, what would happen is the composite would wear and break free of the framework, of this mesh. And the reason for that is it wasn't chemically integrated into the mesh. In order to repair these areas, we'd have to place larger amounts of composite over the top. In fact, we'd end up with over-contouring, difficulties in oral hygiene, maintaining them, and really putting the teeth at risk for periodontal involvement and recurrent decay. In the case of the metal mesh, sometimes the patient would perforate through on the lingual surfaces of maxillary incisors, and the metal would be sticking out, and it would be sharp and uncomfortable to the patient's tongue. So the failures that we saw with splinting, with embedded wires, pins, nylon, all sorts of meshes, were that the composite didn't really chemically join with these materials. The composite surrounded them, the composite was reinforced, but cracks that occurred within the composite would propagate through the material. In fact, looseness would occur, repairs were very frequent. And these frequent repairs were because of the loading stresses that we saw on periodontally mobile, occlusally compromised teeth, both in normal function and in parafunction. And some patients took it into their own hands. This patient used dental floss, and in the mirror, she was able to thread it through these interproximal areas to hold the teeth together. She was able to maintain those teeth, but the two central incisors were completely out of the periodontium. When the patient came into our emergency clinic, we needed to remove this splint. The teeth were lost. The patient eventually had all the teeth cleaned, scaled, and root planed, had a periodontal treatment plan, and ended up with a removable partial denture. But what we're going to talk about is a new class of materials for splinting. Other clinical uses. We're going to talk about fiber reinforcements for dental composites. And when we talk about fiber reinforcement, think about some of the new airplanes that are being made lightweight, using carbon fiber reinforced resin materials. These are very similar, although the fibers we use in dentistry are a little bit different. We use glass reinforced fibers, polyethylene reinforced fibers. But the technology is there. It's an extension of what's been done really in the general things that we see and do every day. Fiber reinforcement with composites were really introduced around 1992. And I, in fact, have some cases that are now going on 12, 13, 14 years of clinical success. These bondable fiber ribbons and straight fibers are either unidirectional glasses, like the splinted material from Pentron, braided glass fibers, although the most popular and the one showing the greatest durability clinically are a lock-stitch Leno-weave polyethylene, the Rib-On material from Seattle, Washington. These materials, the Rib-On, the polyethylene, is very tough and durable. In fact, we need special scissors to cut these materials. They're so tough. They're based upon aramid fibers, similar to the fibers that are used in bulletproof vests. These are very tough fibers. When used in fishing, these fibers at 1/4 the diameter have the strength of 4 times the thickness of nylon. They have different fiber configurations. The Rib-On THM material and the original Rib-On are a lock-stitch lino weave. These weaves end to be crack stoppers. The Connect material, also a polyethylene material, is basically a braided weave, which tends to change in its shape, and the fabric shifts within the composite. The Splinted material, which is a glass fiber material, either as a unidirectional glass or as a woven braided fiber. From the research that's been done, the lock-stitch weave tends to hold the composite at better flexural strengths, flexural modulus, as also it's more easily manageable, easier to place. When we look at the flexural strength of fiber reinforcement of a composite, if we use a unidirectional glass will give us some of our greatest flexural strength improvements, reinforcements of the composite. A thin lino weave, the Rib-On THM material, gives us very close to the same flexural modulus. Yet using a polyethylene, we have a much more durable fiber. The regular lino weave, which is actually thicker, gives us about a 15% decrease in the flexural reinforcement of composite resins. Now keep in mind that you think thicker is going to give us better, and really it has to do with the fiber configuration. When going to a thinner fiber, which is basically a 100 denier thread of polyethylene, we can actually straighten out the fibers within the weave, within the weave itself, and end up with a good result. And this is based upon research I've been involved with a co-researcher, Vistaf Kabari. And we've investigated fiber reinforcement materials over the last 15 years and seen a lot of success clinically with these materials. In fact, when breaking fiber, the mode of failure of a continuous fiberglass is that when the crack starts in the composite, it actually propagates through the glass. The glass is a brittle material. The glass pulls out and splinters. You get total separation of the composite and the fiber itself. So you have a high flexural strength, but when a flaw occurs within the composite, the crack starts and it continues all the way through. In fact, here you can see an SEM from a master's thesis of the pullout of the glass from the composite itself so that the crack goes all the way through. With a polyethylene, ultra-high molecular weight polyethylene fiber, the failure mode is not cracking. The composite cracks. The polyethylene lock-stitch weave of the Rib-On stops that crack, and that the failure mode becomes bending. And so the crack stops at the fiber, at the nodes of the fiber weave. In fact, when we look at an SEM of the failure mode, we see absolutely no pull-out of fibers. The crack stops. It prevents shifting of the fiber architecture so that we're going to end up with a much stronger, durable fiber reinforcement for a periodontal splint or for a directly placed fiber bridge. So this unique patented lock-stitch weave, which is very similar to the weave that's used in climbing cords. If you're climbing the sides of mountains, if you're rappelling from walls, the weaves that they'll use of those cords are going to be lock-stitch. And the reason they do that is over time the cord's going to wear and fray. We don't want the cord to fray and then snap. In fact, each separate portion of that cord is actually individualized to keep its strength, so that the nodal design of this dense fiber weave of the Rib-On contributes to the crack stopping ability when the composite cracks. So we've looked at the science of fiber reinforcement for splinting, fiber reinforcement for direct single tooth placement fixed partial dentures. Let's take a look at some clinical cases and the technique for placing these fiber splints, these fiber bridges. In this clinical case, we have a patient who has a chief complaint of discomfort upon function. Our clinical findings show a loss of gingival attachment, some recession. We have a grade 2 mobility of the incisors. The canines have less than a grade 1 mobility. The patient's complaining that the teeth are starting to space out. They want to know what can be done. When we look at the radiographs, we see evidence of about 40% bone loss of the 4 mandibular incisors. We want to scale and root plane these teeth. We want to do our initial preparation. We want to get these teeth periodontally healthy. We want to control the soft tissue inflammation. Inflammation contributes to mobility. Once we've gone through our scaling and root planing, we're now ready to proceed with the splint. To place the splint, we're going to be using adhesive materials. Our best isolation, our best control is by placing a dental dam. And a dental dam for periodontally involved teeth is very easy to place. We'll use just the medium hole of the rubber dam punch. We'll punch holes from the first premolar to the first premolar, or from the second premolar to the second premolar, depending upon each clinical situation. And then we'll place the dam over those teeth. Because the teeth are periodontally involved, the teeth move with the dam, and the dam goes on very easily. We can do this with or without local anesthesia. The dam also offers the benefit that it's not unusual for a patient with gingival recession to have some root sensitivity. By placing the dam, we're covering those root surfaces so that through the entire adhesive procedure of etching, rinsing, drying, the patient's much more comfortable. If the patient prefers, we can use a local anesthetic, and for myself, I do 2 mental blocks using Septicane, and I can control any discomfort the patient has. I clean the teeth. I'm going to clean the teeth with prophylaxis angle using a non-fluoridated prophy paste or some flour of pumice and water. If you were to use fluoridated prophy paste, that isn't it isn't contraindicated, but we want to make sure we remove all stain. We want to keep the enamel clean. Interproximally, we'll clean the teeth using some diamond strips. The key is we can't bond to stained enamel. We have to bond to enamel that is accessible to the phosphoric acid etchant. We want to minimize the bulk of the composite on the facial surfaces. That we know from our experience with the original Maryland Bridge splints in the mid-1980s that these periodontally involved teeth want to walk out, break free of the splint. By placing composite on the facial, we establish really the teeth from moving facially, but also from twisting and torquing. These are mobile teeth. These many times are depressible. We take a thin diamond and we barrel into the facial interproximal surface. We extend the diamond preparation 0.5 millimeter on each side of the interproximal, and in fact, we're not necessarily breaking contact, but we're going into half the proximal contact, similar to a porcelain veneer preparation. This allows us to place composite on the facial, the splint on the lingual. We create a 180-degree wrap with the splint in place. We stabilize the teeth. We'll hear more about that later. So the teeth are cleaned before the bonding procedure so that we can get our optimal adhesion on the facial and lingual surfaces. We're now going to measure for the ribbon. We're going to look at the facial, and we're going to go to the mesial of the canines. We're going to use dental floss or dental tape to measure this and cut it. And then we'll measure out the length of the ribbon that we'll be using on those facial surfaces. For the ribbon, we need to cut it with a special scissors. For other materials, we need special scissors. And so for the ribbon, we'll be cutting the polyethylene with the special scissors. Suture scissors, crown and collar scissors won't cut this. We don't want to fray the rib-on. The rib-on keeps its same length, its same shape. It doesn't unravel. That's what differentiates it from other braided fiber materials. Lock stitch Leno weave rib-on does not come undone. It doesn't fray. It holds its shape. The ends stay in place. We're going to use a wetting ribbon adhesive. We can use the rib-on wetting resin, or we can use a 5th generation adhesive, making sure we evaporate out all the solvent, or we can use a 4th generation adhesive. At the dental school, we use Scotch-Bond Multipurpose. We use the rib-on wetting resin, or we use Optibond Solo Plus. When we use Optibond Solo Plus, we blow a gentle airstream over the adhesive to evaporate out the solvent. When the fibers become wet, they become translucent. We go from opaque fiber to translucent fiber, a much more aesthetic fiber. After we've wetted the rib-on, we'll use a patient napkin to remove the excess resin. With the rib-on slightly wetted, we'll cover it, put it in a dark area so we don't get any polymerization of the fiber with the resin prematurely. We now go back to the teeth. We etch the enamel on the facial and lingual surfaces, the facial lingual for 30 seconds, the lingual surfaces 30 seconds, the facial surfaces 30 seconds, where we've prepared the enamel. We then rinse the teeth for 10 seconds with an air water spray so we get all the etchant off the teeth. All the blue will be gone. In fact, when we dry the etched enamel surfaces, they'll have a frosty, white, opaque appearance. We've demineralized the enamel rods. With the surfaces etched and dry, we're now ready for the next step. The next step is creating an anatomic blockout of the gingival embrasures with a polysiloxane impression material. We can use a fast-setting medium body or a fast-setting heavy body material syringed into those gingival interproximal areas. We've etched the teeth first because we want to make sure there's no moisture trapped in this anatomic blockout. The reason for using the anatomic blockout is it's a passive blockout. In the past, when we used wedges, we would actually move these teeth in different positions. Also, this anatomic blockout minimizes the finishing when we've completed the splint. It's chemically incompatible with the bonding resin, with the composites that we use. We have total control of these embrasure areas. We then go in and we place composite, adhesive and composite on the facial surfaces. We adapt this composite. We use a burnisher to adapt it. We then go in with a thin plastic filling instrument to create separation. And in fact, before light curing, it looks like individual teeth, even though we've sealed the interproximal embrasure areas, the interproximal contact areas. It stabilizes the teeth so that when we place the ribbon and the composite on the lingual surface, the teeth won't move facially, or on the maxillary where we place it on the facial, it won't move lingually. It means that the occlusion will be constant through the procedure. We're sealing the teeth. We're establishing that 180-degree wrap with the fiber splint on the lingual, and we're ending up with a result that will give us greater durability. What happens if we don't do this wrap? Well, if we don't do this wrap, these mobile teeth that are depressible, that shift and torque and twist within the periodontium, will break free. In fact, for this case, you can see no composite was placed on the facial, and a mere year after placement, it's broken free. In order to repair this, we need to replace the entire splint for this patient. And this splint was placed for periodontal stability, but was also placed to replace a missing lateral incisor with a composite pontic. So once we have the composite placed in the facial, we place adhesive on the lingual surfaces. You can see how that anatomic blockout will work. With the adhesive lingual, we then place our composite on the lingual surface. will almost empty an entire compule, entire pre-dosed, preloaded tube of composite. Some people will use flowable composite for placing these splints. I personally like to use a nano-filled, a nano-hybrid composite that is not too stiff. It has to have some give to it. Once the composite's in place, I'm going to embed the ribbon into the lingual surface. I'm going to adapt it into the interproximal areas. I'm going to have the fiber as close to the tooth, to the adhesive and the composite as possible. We've not light cured anything. And this adaptation gives us a thin film of fiber up against the enamel surfaces. Once we've got the fiber totally embedded in the composite, it's covered with composite, it's as closely adapted to the enamel, it's being placed in the interproximal embrasure space, interproximal contact spaces that are present, the lingual embrasures, we can then light cure. We want to make sure the composite does cover all the fiber and that we have minimal excess before light curing. Because we place composite on the facial, we don't worry about the teeth moving facially when we put our forces to adapt. When I'm placing my original fiber, I'll take cotton pliers to stabilize the fiber as I'm placing it. I'll use a burnisher to embed it within the fiber into the composite as close to the enamel as possible. I'll then use a thin PFI instrument to force it into the lingual embrasure spaces. Once I've placed it, any areas where this fiber showing through, I'll place a flowable composite. I'll then go in and light cure everything for 30 seconds a tooth. Note the size of the tip of the light curing unit you're using. Make sure the tip is over the area you're curing and cure for 30 seconds. We cure for 30 seconds because we're not only curing through the composite, we're curing through the fiber. The fiber acts as a barrier for light curing at a faster rate. And so the kinetics of light curing, of polymerization, require 30 seconds a tooth to light cure. Once we've light cured, we finish and polish. We remove any sharp edges. We use discs to finish the facial surface, to marginate it. We'll use rubber and silicone abrasive polishers. We'll use polishing paste to finish these areas. When we are finished placing the composite, we pull out the polysiloxane blockout. Look at the blockout removed before I've done any finishing and polishing, and you'll notice how anatomic it is, that I'll need to do very little gingival finishing, gingival polishing. In fact, when I placed the composite, I had very little excess. So my finishing and polishing is going to take me a minimal amount of time. With the dam removed, we've now achieved a stability of these mobile teeth. We've established aesthetics. In fact, if you look from the incisal view, you can see I've created some facial embrasures, lingual facial embrasure form, so that when you look at it, these teeth look somewhat separate. Radiographically, this splint is apparent. We can see if there's any decay forming underneath the splint, if there's anything going on periodontally around the splint. The fiber itself is radiolucent. In fact, the reinforcement of the composite occurs because the fiber itself increases the volume of filler. We know fillers reinforce composites. And we've created a laminated structure. When the teeth are misaligned, we sometimes need to place channels in the teeth for mandibular splints on the lingual. The channels allow us to place the fiber more easily, better adapted to the teeth. For this misaligned case, we went in and created a channel. We created a channel using a 35 inverted cone burr to a depth of 1/2 to 0.8 of a millimeter. The indication for the channel for mandibular splinting is misaligned teeth. The width of the channel will equal the width of the fiber ribbon. The channel will extend from the mid-canine to the mid-canine on both sides. It'll be all at the same height at the transition between the middle third and the incisal third of these teeth. Here we can see a 2 millimeter wide ribbon sitting into the prepared channel. It's easier to adapt it when we place it. Can you use a channel for every case? Yes, you can. You might say, well, it doesn't become reversible. In reality, once you place a splint is for life. These teeth will be splinted for the patient's lifetime. The periodontal condition, the periodontal mobility, the compromise in the support is not something that heals. It's something that we control. So here we're seeing for this misaligned case a channel extending from the midlingual of the canine to the canine on the other side from 22 to 27. You can see it's been placed with an inverted cone burr. It's the width of a 2 millimeter wide ribbon THM fiber. Here we're looking at the completed splint, and this patient has about 60 to 70% bone loss. So we've stabilized these teeth. The patient no longer complains about discomfort when eating. They're easily maintainable. Look at the anatomy of these gingival embrasure areas. A patient can go in with a flossing aid. They can go in with interproximal brushes. We can maintain the gingival health of these splints. When we splint maxillary anterior teeth, we need to look at special consideration. When we place a splint on the lingual surface, the occlusion will interfere with the splint. We'll see functional wear of the composite, in many cases exposing the fiber. The tensile side of the splint is on the facial surface, and that gives us our greatest reinforcement. Once again, these splints are over a patient's lifetime. These are not provisional or temporary splints. These are lifelong commitments. In fact, they may lead to the placement of conventional fixed partial dentures for the patient. In this case, we can see functional wear of the composite. For this patient, the fiber was placed for orthodontic retention. The fiber was replaced because the patient's congenitally missing a lateral incisor, and a composite pontic was placed. The evidence supporting the facial channel in the literature refers to both the occlusion and the needs of the fiber architecture for the greatest longevity and durability of the splint. So for this patient has a removable partial denture. We have it in place. You can see the clasps on the canines, number 6 and number 11. We can see the bone loss, that we have about 65-70% bone loss for this patient. We need to place the splint so it doesn't interfere on the facial surface with the partial denture. The teeth are cleaned. We use no local anesthetic. We clean the teeth thoroughly. We clean the interproximal areas thoroughly. We placed a dental dam. We created a channel with the 35 inverted cone burr. For this case, we're going to be using a 3 millimeter wide ribbon THM, thin high modulus ribbon. And the reason we're using a 35 inverted cone burr and a 3 millimeter wide is for each millimeter increase in the width of the fiber, we get a logarithmic increase of the strength and reinforcement of the composite. This patient's missing the predominance of her posterior teeth. When she doesn't have her partial in place, she's creating excessive forces on these maxillary anterior teeth. In fact, before placing the splint, we do an occlusal adjustment to remove all fremitus so that these teeth are not going to have any unusual forces. We use local anesthetic. We do perforate into the dentin in some select areas. We're not concerned. We do barrel a little bit with a round burr into the lingual surfaces to create our 180-degree wrap. We have a 3 millimeter wide channel that we've placed with the 35 inverted cone burr. We measure our ribbon from the middle of the canine 6 to the middle of the canine number 11, and then we cut our ribbon THM to that width, to that length. We go in and we wet the ribbon with the Rib-On wetting resin. We then will take a patient napkin to remove the excess resin from those surfaces. We etch the enamel for 30 seconds, the dentin for only 15 seconds. After we've etched those surfaces, we'll then rinse and dry those surfaces, leaving the enamel frosty in appearance, and the dentin will be wetting to leave it somewhat glossy. We're now have placed an anatomic blockout of a fast-setting PVS heavy-bodied impression material. We get an anatomic blockout on these surfaces. We place our adhesive. We then place our composite resin. And then we place and push our fiber into the interproximal areas. We're having the fiber adapt to the teeth, adapt to the interproximals, and embedded within the composite. Here we're looking after light curing, the composite's been placed. We've minimized the excess composite on these teeth, and we know that the shade very closely will match this patient's teeth once the teeth rehydrate. Here we're looking in the top left-hand side, the preoperative view, and right after placement. We've created individualization of the teeth. We have the fiber embedded within the teeth. The patient now will tell you that the teeth are more comfortable when they bite down, when they eat on these teeth. So we've created stability. We've improved prognosis long-term for these periodontally involved maxillary incisors and canine. And we've also gotten an aesthetic result. It is able to be maintained. The patient can get interproximally between these teeth with an interproximal cleaning aid. At the 4-year recall, look at the periodontium, look at the teeth. These are doing quite well. So that we can get these long-term results and improve the prognosis periodontally for these patients. Let's look at some long-term cases. Here we're looking at some mandibular incisors. We can see that we have close to 80% bone loss. Look at the calculus. This patient, in fact, is a smoker. We're going to clean these teeth. We're going to do scaling and root planing. We're going to get the gingival tissues as healthy as possible. Gingival inflammation contributes to mobility. Occlusion contributes to mobility. Here we can see how much loss of attachment, loss of bone that we've seen. After initial periodontal therapy, we now go and we place our splint with the techniques that we've described. This Rib-On splint is now in place. It's aesthetic. It's able to be maintained. It's very hygienic. The patient reports that they're able to function on these teeth again, that they're comfortable. Patients see now on a routine of every 3 months. 3-month recall. This is a periodontal patient. This is a patient that isn't done. This is a lifelong commitment for periodontal care. Let's look at the 7-year recall. This is as the patient walks in at the 7-year recall. Look at the calculus on the facial. The patient's still smoking. You can see that these composites are reasonably stain resistant. We're maintaining the height of the gingiva, the height of the bone. We've stabilized these teeth. We've improved prognosis. When we originally saw the patient, our concern was we'd lose the 2 central incisors in the mandibular arch, and in fact, we've maintained them over 7 years. For this patient, at 8-year postoperative recall, look at the bone loss. I mean, we've got 70–80% bone loss on this lateral incisor, and yet with the splint, we've been able to maintain it. The patient needs to be committed to a long-term recall and a regular recall for periodontal care of the dentition. Or for this maxillary case, a replacement of a congenitally missing lateral incisor. We have some orthodontic retention, and at the 4-year recall for this patient, they've worn through the lingual of the composite. This is a orthodontic retention. This is a provisional, long-term provisional bridge because the plan is for the patient to get an implant. Every time the patient wears through the composite, we'll use a round diamond, roughen the composite, etch adhesive, and flowable composite to repair this fuzzy fiber reinforcement material sticking through. Here we're looking at the case of an 11-year postoperative recall. The patient has the composites removed, will have the pontic removed, will get a final implant crown, and also porcelain veneers. The patient went back to their referring dentist to have these procedures done. We can also use fiber reinforcement materials to create a natural tooth pontic bridge. We can also use it for a composite pontic bridge that we plan. And this can be done in a single visit where on that day you're planning to remove a periodontally involved incisor, or the patient loses their tooth due to trauma and we need to do an immediate aesthetic emergency treatment for the patient. For this patient, we have an abscessed lower incisor, mandibular incisor. You can see there's no bone loss. As part of the treatment, and this patient's in a periodontal study, and that's why the teeth haven't been thoroughly cleaned, we're going to be removing the incisor. When we remove the incisor, we apply some pressure with some gauze for 30 minutes, and we're going to use the patient's own tooth to create a pontic. There are many different ways to create pontics. We can use the natural tooth crown. We can create a composite pontic. Some people use denture teeth. I found both the composite pontic and the natural tooth crown work the best. For this patient, the aesthetics and the height of this incisor is out of the plane of occlusion, so we're going to replace it back into the plane of occlusion. We remove the infected tooth. We're now going to cut off the root and create an anatomic pontic made from the patient's own natural tooth crown. This, I find, is the best way to get a result if the tooth's usable. I'm going to cut the length of the tooth based upon the length from the incisal edge of the present incisors to the gingival extraction site so that I'm extending slightly into the extraction site. By extending slightly into the extraction site, I'm able to create an anatomic pontic that looks like it's emerging from the gingiva. This emerging pontic looks like a natural tooth and not a pontic, not an artificial tooth. I'll cut the tooth off using a diamond or a burr. I'll then shape it with a finishing burr to create a rounded bullet shape to the pontic on the tissue-borne, on the gingival-borne surface. I'm going to fill in the root canal itself that I see with a bonded composite. I create a channel that I prepare in the middle third of this incisor using a 35 inverted cone burr. And it's all right for me to go into the dentin in these areas. So I've cut the tooth crown from the root, so only the crown is remaining. I then go in and place my dental dam. The dental dam does several things for me. It offers me the benefit of not having any contaminants in these surfaces. Keep in mind the tooth was just extracted. I'm going to create 2 class 3 preparations adjacent to the pontic so that the channel that I've created, the groove on the lingual of the natural tooth pontic, will match up with the class 3 preparations. I'm going to reattach this tooth crown to the adjacent incisor teeth using a fiber ribbon bonding technique using dental colored tooth adhesive composite. I'm cutting the fiber ribbon to length. I'll cut it from the number 22 to number 27, midway to 22 and 27, measuring it on the facial surface. That'll be my longest length of the fiber. That longest length of the fiber is for periodontal splinting. I'll cut a smaller piece of fiber to have a second piece as a connector within the class 3 preparations in the channel. Just as I did with my periodontal splint, I'm going to use a diamond to prepare into the interproximal embrasures. I'm going to roughen up the adjacent sites to the pontic with a fine diamond as well, and then I etch the sites for pontic attachment. I'm etching the sites for pontic attachment before I do any other etching. I want the composite the natural tooth Pontic in place with the adhesive composite on the facial, and then I can treat the entire case like a periodontal splint. So I etch for 15 to 30 seconds on the mesial of each tooth, holding the tooth crown with the cotton pliers. I place it in the orientation that I want, and then I light cure it. The Pontic is now in place. With the Pontic in place, I'll now extend my Class 3 preparations to be at the same height as the channel on the lingual surface of the natural tooth Pontic. I now go in and I'll etch all my interproximal areas. I'm treating this like a periodontal splint at this point. I'm going to etch for 15 to 30 seconds on the facial and lingual. I'm going to rinse all the etchant off the teeth and dry it off before I place my polyvinyl siloxane blockout, my anatomic blockout. I then place my anatomic blockout. I'll place a matrix band to the distal of both canines so that no adhesive or composite gets on the mesial of both first premolars. I've got my blockout in place in the Pontic area and in all the areas where the splint will be placed from number 22 to number 27. I place my facial adhesive and facial composite. I'm creating that 180-degree wrap to stabilize the teeth for placement of the splint, for sealing the interproximal areas. And remember, I prepare those areas so that I can create separation between the teeth and end up with an aesthetic facial result. I'll then light cure the composite. I'll place bonding agent on the lingual surface, my composite into the Class 3s and the channel on the teeth and on the lingual. I'll place a smaller piece of Ribond into those channels, have it closely adapted in the Class 3s and the lingual surface, and then I'll place my longer piece of Ribond that I'm using for my periodontal splint, and I embed it into the composite, similar to the technique I described earlier. With the fiber ribbon embedded within the composite and closely adapted to the enamel to get as thin a film of composite around the ribbon as possible, I'll take a PFI to adapt it into the lingual embrasures. I want the fiber as closely adapted to the teeth as possible. With the composite, the fiber, everything adapted, I complete my periodontal splint by light curing the linguals for 30 seconds a tooth. I check the occlusion on the existing splint to make sure nothing's unusual. I've ended up with an anatomic splint, a splint that is aesthetically pleasing. Remember, we removed this tooth today because of an emergency. There was a periodontal abscess. The patient was in pain. We can go back later to do some shaping if we need to. With the teeth adapted, with the teeth in place, the patient no longer complains about that area being sore. The patient's able to keep the area clean hygienically. And here we're looking at this splint now in place for several years. It's functioning well. The patient's taking care of it. We've improved the periodontal prognosis for this patient. Here we see it at 36 months, the splint in place on the facial and on the lingual. There are times where we're placing these single tooth bridges for situations we don't expect. For this patient, the patient got porcelain veneers placed in March of 1988. Patient had tetracycline staining. They liked the position and shape of their teeth. They didn't want their teeth to look like a piano keyboard. We placed porcelain veneers, masked the discoloration due to the antibiotic staining, and sent the patient away. When the patient came back for routine recall, we noticed that there was a red spot on the lingual surface of number 9. We looked at it. We could get under it. We took a radiograph and noticed internal resorption. The patient went back to their own dentist, and their own dentist said, I can take care of this. He removed the resorptive area. He put calcium hydroxide over the pulp itself, and he placed an amalgam restoration. He removed the excess soft tissue with an electrosurgery unit. So here we are, a little over 2 years from when the porcelain veneers were in place, with a tooth with a potentially hopeless prognosis. In fact, the patient was told that the prognosis for this circumstance is the loss of the tooth. The patient's dentist said, let's try to save it, and in fact, this was done heroically. 6 months later, on a radiograph, we noticed the resorptive lesion was continuing around the amalgam. The decision was made to remove the tooth and create a pontic of the porcelain veneer on the natural tooth crown. This is before we had fiber reinforcement materials. We removed the crown from the root and then removed the root separately. We didn't want to damage the porcelain veneer during the extraction procedure. We created a template using a polysiloxane putty matrix to hold the tooth in place. We cut class 3 preparations in the central and lateral incisor, and we created a channel in the tooth crown itself. We placed it using an orthodontic square wire with composite on the facial and lingual surfaces to get things stable. You can see that this is the day of tooth extraction. Over the years, the patient came back several times for repairs that the composite would chip and break. So we decided to go in 1995 and replace the wire with the rib-on material. You can see the class 3 preparations adjacent to the pontic where the connector will be placed. We've created a channel in the lingual of the pontic tooth, of tooth number 9. We're going to use a 3 millimeter wide piece of rib-on in that and 2 thicknesses to create a beam effect. The double thickness of fiber with composite sandwiched in between gives us increased strengthening of the connector between these teeth to create our fixed partial denture. We replaced the wire with the 2 thicknesses of ribbon. We etched, we placed adhesive, we wetted the 2 fibers of ribbon, we placed composite. And here's the result when the patient left that day we did the replacement. On the radiograph, you can see that the fiber is radiolucent. It's increasing the structural strength of the composite in that interface. We created as best we could the aesthetics between there, bonding to the veneer using silane and roughening the porcelain with hydrofluoric acid as if we were doing a porcelain repair with composite, and we've placed this. The plan in the future for this patient is to have the placement of an implant crown. The patient at the time couldn't afford that procedure. She was raising 2 small children, and she said, well, let's continue with this. If we have to repair it, we'll repair it. It seems to be functioning very well. Now, at 8.5 years, you can see how the veneers are functioning, and the veneers are actually over 15 years, but also how the splint is functioning, how this fixed partial denture from number 8 to number 10 is functioning. This is the last image I have because the patient went back to her dentist, had this removed, and had an implant placed and an implant crown placed to restore number 9, which was missing. There are other clinical uses for fiber-reinforced composites. These clinical uses include periodontal splints, as we've just discussed, fixed partial dentures that we place directly, but labs can fabricate fixed partial dentures. We can directly place posts using these fibers by placing them into the root canal using dual-cured composites. We can use this to splint teeth after trauma. Other clinical uses include reinforcing endodontically treated teeth and large cusp replacement restorations, placing the fiber into the pulp chamber up against the tooth within the pulp chamber. Fiber's been described for use for orthodontic retention, for reinforcing long-span provisional fixed partial dentures, reinforcing implant provisionals, and in fact, reinforcing denture bases, and also reinforcing occlusal appliances. Fiber embeds itself within the resin itself it becomes chemically incorporated, it creates a laminated structure to make the resins themselves stronger than if no reinforcement material was in them at all. When we think about using fiber reinforcement materials, we think about a quote from Albert Einstein. We don't need to think more. We need to think differently. And hopefully the use of fiber gives us an extraordinary solution to ordinary problems.